Welcome to this explainer. Today we're taking some pretty dense medical research and transforming it into an actionable toolkit to help us all understand the comprehensive approach to managing chronic pain after cancer. Specifically, we're zooming in on the clinical practice guidelines published by the American Society of Clinical Oncology, or ASCO for short. Now, this is an absolutely crucial topic because, as we know, survivorship is an evolving journey, and the medical community is finally codifying exactly how to manage the long-term realities that come with it.
Okay, let's jump right in. 14 million. Thanks to some truly extraordinary advancements in modern medicine, there are roughly 14 million cancer survivors currently living in the United States alone. And get this, 2/3 of those individuals are surviving 5 years or more after their initial diagnosis. I mean, that is just a monumental achievement, right? It's a true testament to the relentless progress of oncology.
But here's the catch. That incredible survival rate actually hides a pretty stark reality. Up to 40% of those survivors are forced to live with persistent chronic pain. That is a staggering portion of the population. And things like the type of tumor, how invasive it was, the specific treatment regimen used, and even how well initial pain therapy worked, all of these are predictors for this ongoing pain. This isn't just a minor inconvenience. It's directly associated with an impaired quality of life. The battle, unfortunately, doesn't always end just because the cancer is gone.
So, to tackle this head-on, we're mapping the ASCO guidelines directly to the patient journey. We are going to cover the burden of survival, screening and assessment, non-drug pain interventions, pharmacologic treatment options, and finally, opioid use and safety.
Starting right off with Section 1, the burden of survival.
You know, for years, survivors have really struggled to get adequate pain management. And you might be wondering, why is that? Well, it's largely because historical guidelines were heavily focused on relieving acute pain during active treatment or pain associated with advanced terminal disease. So patients who were totally free of cancer after treatment or who were living with it as a chronic illness were kind of left in this frustrating gray area. There simply wasn't a broad, evidence-based consensus on how to manage their long-term comfort and functional recovery. Until now.
Moving right along to Section 2, screening and assessment.
The absolute bottom line from the ASCO guidelines is clear-cut. Clinicians must screen for pain at every single encounter. And it can't just be a passing, "Hey, how are you feeling?" The panel actually recommends using quantitative or semi-quantitative tools like a numeric rating scale to trigger a real in-depth interview. If you're reporting persistent pain, your doctor should be exploring the multidimensional nature of it. They need to know the descriptors, the distress it's causing you, how it impacts your daily function, and all the related psychological and social factors. Plus, they always need to evaluate and monitor for recurrent disease or second malignancies if you report any new onset pain.
Now, a massive part of this assessment is validating your pain. The ASCO panel explicitly recognizes that life-saving treatments like chemotherapy, radiation, or surgery directly cause specific, long-lasting chronic pain syndromes. We're talking about things like chemotherapy-induced peripheral neuropathy, arthralgias and bone complications from hormonal therapies, radiation-related tissue damage, and surgical pain syndromes like post-mastectomy or phantom limb pain. The takeaway here? Your pain has a distinct, recognized medical origin. It is absolutely real.
Next up, Section 3, non-drug pain interventions. You actually have an incredibly broad non-pharmacologic toolkit to pull from when building your multimodal plan. The ASCO guidelines reviewed a ton of trials and found that balancing these different elements is the key to success. This includes physical therapy and exercise, which we know improves physical function, integrative therapies like acupuncture and massage, which have been shown to significantly reduce cancer pain, interventional therapies, think targeted nerve blocks or kyphoplasty for vertebral fractures, and of course, psychological approaches.
Let's cut through some of the medical jargon you might encounter on your journey and look at a couple of specific examples. Psychological approaches, like cognitive behavioral therapy or CBT, are fantastic for helping manage the functional and emotional impact of pain. Systematic reviews actually show that acceptance-based interventions and mindfulness have a really significant effect on improving your quality of life. Then, over on the physical side, you have tools like TENS, which uses physical neurostimulation to improve comfort without drugs. The ultimate goal here is to maximize your daily function, using every conservative tool available before ever turning to medication.
Which brings us to Section 4, pharmacologic treatment options.
When it is time to escalate to medications, the goal is always enhanced comfort with minimal side effects. It's a step-by-step process. It starts with baseline systemic non-opioids, your standard NSAIDs and acetaminophen. But if the pain persists, especially if it's nerve pain, the guidelines recommend stepping up to adjuvant analgesics. This includes specific antidepressants like duloxetine,
and anticonvulsants like gabapentin, which have proven to be highly effective for neuropathic pain. One quick note though, the guidelines explicitly say that corticosteroids are not recommended for long-term use just to relieve chronic pain, simply because of toxicity concerns.
So, what about medical cannabis? Well, the panel maintains a very clinically neutral, evidence-based stance on this. They point out that while it shouldn't be your absolute first option, mainly due to a lack of standard formulations, systematic reviews do show it can provide modest, well-tolerated relief for really stubborn chronic pain conditions. Depending on specific state regulations, clinicians can definitely consider it as an adjuvant analgesic after carefully weighing the potential benefits and risks with you.
Finally, we have Section 5, Opioid Use and Safety.
Because safety is absolutely paramount, ASCO mandates that clinicians strictly differentiate between these 4 terms to avoid stigma and ensure you get the proper care. The crucial thing to understand is that physical tolerance, which is just needing a higher dose for the same effect, and physical dependence, experiencing withdrawal if stopped abruptly, are completely normal biological responses to long-term opioid therapy. Abuse and addiction, on the other hand, are behaviors characterized by a loss of control and compulsive use despite harm. Getting this vocabulary right is essential for having open, honest communication with your healthcare provider.
Now, if conservative management fails, clinicians rely on what's called a universal precautions pathway for a trial of opioids. It involves 4 strict steps to safely select candidates. First, they assess and stratify your risk through interviews and records. Second, they minimize risk by making sure you've optimized all other non-opioid treatments first. Third, they tightly monitor use through tools like pill counts and urine drug screening. And fourth, they respond immediately to any aberrant behaviors by restructuring the care plan. It is a highly structured framework, and it's designed specifically to keep you safe while genuinely trying to improve your daily function.
We really hope this explainer has equipped you with the knowledge of a structured, multimodal toolkit. You are not alone in this, and chronic pain absolutely does not have to be the permanent cost of surviving cancer. You now have the ASCO blueprint in your hands. So, the big question is, how are you going to use this knowledge to advocate for your quality of life at your very next appointment?